I'm so glad you could all dig out your cars or somehow get here today for the Global Health meeting. We're just delighted that Renslow Sherer can join us to tell us about the important work that he's doing in China, in Hubei province. Let me just say a few words about Renslow, and then I won't take up any more of his time. At the university, Renslow directs the International HIV Training Center. He's been a nationally recognized leader in HIV disease prevention, care, research, all the way back to the early 1980s, when, believe it or not, I mean, this is really a hard thing to believe, in 1982, Renslow founded the first HIV clinic in the city at Cook County Hospital. When you remember that the first cluster of 5 cases was reported out of Los Angeles in 1981, it is staggering to think that as early as 1982, Renslow had identified HIV as a very important area for care and for training and for research. His model of an ambulatory facility to take care of HIV patients became locally renowned and had great play nationally also. In 2003, Renslow became the director of HIV STI TV for Project Hope. Since then, he's led health worker training in China, North Africa, the Western Balkans, the Americas, and in HIV disease, and has worked with orphans and families in sub-Saharan Africa and in the Americas. So today's topic is ART scale-up in Hubei province, China. What happens next? Renslow, it's great to welcome you.
Thanks. Thanks, Mark. When you describe it all, that does feel like a long time, and I feel like I'm staggering for all of those many years. I would say Dan Bronner was around at the very beginning at the county hospital as well, so he could also report to you on those events. What I want to do is to answer my own question and describe what that process was in Hubei province with health worker training, and then segue to the medical education reform project that is actually ongoing, which actually some people in this room are participating in, and to try and frame that in sort of the ethical considerations. And I thought I would actually cite Mark and his work in this regard. I think it's been an interesting theme Wednesday after Wednesday. If you've come to these talks, people have described their international work. This has been a global health conference at its core, and then talked about ethical issues that have come up during that time. And as a clinician, I would say this book very nicely gives a framework for thinking about ethical issues. So in his book, Mark talks about medical indications and the principles of beneficence, non-maleficence. Basically, we try to help our patients, we try not to harm them. And when you have a global health project, that's, of course, the same kind of interest that you bring to bear. He talked about patient preferences and respect for autonomy, a patient's right to choose, or in this case, maybe our contractors or our host countries' right to choose, and is that being respected to the extent possible within our project, within their own law and internal regulations. And I think both of those apply, and so I'll try to relate to that as I go through this. Of course, there's end-of-life issues, this balance between meaningful life and unnecessary suffering, and I think that also fits in with beneficence. And then these principles of loyalty and fairness, is there any evidence of bias, undue influence? Are we truly doing well in the interests of the issue at stake and the population we're hoping to serve, or is there some other greater gain, either professionally or financially? And I think these are the kinds of things that we've heard Wednesday after Wednesday in these talks, and I think it's really been interesting to participate in that. And to sort of foreshadow these two topics, as you can imagine, There are huge issues to bear in both of these. In thinking about the problem of HIV and AIDS in China, like everywhere in the world, fundamental issues of human rights, of stigma and discrimination that are obstacles to effective care and prevention. There's a particular wrinkle where I worked in Hubei province that the government had actually had a role in the plasma exchange, in the plasma donation programs that led to HIV transmissions, which is really a terrible part of that story. All of the taboos that I think are very familiar and yet continue to obstruct effective HIV programs, taboos against homosexuality, against commercial sex, against drug use. And then again, particular to China, the criminalization of drug use so that someone who seeks care and treatment of their drug use is immediately imprisoned and has to deal with the criminal justice system in addition to their addiction and their HIV. And this is just, you know, a 747 overview of those issues. Kinds of things that then, in thinking about training from a Western perspective in China, both in the HIV training and now in medical education reform, there's a tradition in China of, back to Confucian days, of received wisdom from elders. Younger people should be silent. They should gain the wisdom from the most respected senior member of their culture, society, within medicine, and essentially that's how information is transferred. And compare that to our tradition, increasingly, of self-discovery, promoting lifelong learning, and even challenging authority. We want our residents on rounds to not take Dr. Bronner's word from it, but to go to the books and come back with a better idea if they can come up with one. There isn't a word in the Chinese language for professionalism, just to dramatize how, in some ways, some of the core concepts in medical education really are challenging if we're trying to exchange what we do at Pritzker with Wuhan University. And then there are fundamental differences in medical education. Our first-year medical students are college graduates. Theirs are high school graduates. Our class size is 100. Their class size is 400. So each of these things you'll hear as we go through this. And I'll try to go pretty quickly because I have talked about these things before. You'll see that some of this was for presentations both here and in China, but you'll have to just read only the English. So the story here is that in 2004, I joined Project Hope, as Mark told you. The Hubei Provincial CDC had a long relationship with Project Hope. They were beginning to see cases of patients with HIV. They asked us to help them train their CDC health workers in the management, particularly of antiretroviral therapy, which the government was just manufacturing at very low cost. They were the 5th highest incidence in China. There were about 500 patients known at the time that I first went there. They had an annual mortality of 49%. And the national government had just come to recognize this was a growing threat. They had made free testing, free medical care, free antiretroviral therapy, free social support systems available throughout. So in some ways, we had the perfect storm of doctors starting to see patients urgently wanting help with how to take care of people, drugs that were now available, and the beginning of a support response nationally. Just a briefly for Project Hope, as Mark mentioned, there's physician training and treatment around the world, a lot of HIV prevention work in different contexts, and then some special humanitarian issues. If you heard Matt Winia last week, you heard actually one of those. That's the Project Hope ship, which then became the USS Mercy, and Comfort ships, which are now in Haiti. He described their voyage to Banda Aceh shortly after the tsunami. And a very successful microcredit program for orphans and vulnerable children. Yes?
Where is Hubei province?
I'm going to show you.
Oh, good.
Be patient.
In China.
Yeah, it's in China. And also work in tuberculosis and HIV, both in Africa and in Asia. And in China, where Project Hope maintains offices in Beijing, Wuhan, and Shanghai, a couple of the other things are a very active diabetes program and work on physician specialty boards with the Chinese Academy of Medical Sciences in Beijing. In Wuhan, they helped to create the first nursing school. The only Caucasian dean of a nursing school is Marcia Petrelli, who's in the Wuhan nursing school, and some HIV prevention work. and then a fabulous state-of-the-art facility, pediatric facility, the Shanghai Children's Medical Center, which Project Hope helped to build and develop, and at which we have done HIV trainings, which is one of the top premier, if not the top premier cardiovascular surgery institute in pediatrics in all of Asia. So my story then began in November of 2003 after meeting health authorities with the Project Hope people in Beijing. I went to Wuhan and then to this small town of Junchuan and met this woman who had been bedridden near death with tuberculosis, treated with TB medicines, and gotten substantially better and then relapsed and was found to have HIV because of a plasma donation. And at the time that I saw her, she was among the first patients to receive AZT, DDI, and nevirapine 4 months earlier, and she had gained again 40 pounds, had returned to her normal habit. You can see she was very enthusiastic. So this was a success, and this story helped us enormously. This is well understood at the Hubei CDC, and it was understood that with proper medications, you could see dramatic reversals of clinical HIV. This was the team that we went with. These are the two physicians in the small town in Junchuan. One would stay at this warm house to see patients, and the other would go all through the neighboring community because many of the farmers had to work the fields and would take care of people, and they would do so home visits and in-house visits. This is the local CDC authority, and the rest of us are the Project Hope staff, and this was another gentleman with HIV that we saw that day. Now, just to give a little context, this is AIDS in Asia above, and over a similar time frame, you can see really HIV didn't gain a foothold till later in China, till starting really 97, 98, but with a rapid ascent around the time that we began this project with annual numbers reported of about 50,000, and these are AIDS patients. Yes?
Were they testing though?
Not yet, but they were beginning to start just around this time. So also at this time, recognizing there had been this terrible plasma exchange, and they were beginning to see cases in the Southwest and the Northwest, they started testing.
But there have been TB patients that had HIV, but it was missed.
Oh, there most certainly were likely to have been, yes. It's a little hard to see, but I think you can see it's yellow on yellow, but these are the very first reported individual cases. Mostly these are foreigners. This is the real start of the epidemic in Yunnan province with injection drug use and exchange across the Burmese border. This is Hubei province in the heartland of China. So here's Beijing here, go straight south. Here's Shanghai here. And you can see by 1995, most provinces had reported AIDS cases. By 1998, they all did. This is the Xinjiang province in the northwest, which is actually a territory, and this is along the Silk Route. So heroin from Afghanistan comes into Xinjiang, and I traveled there with Gui Zhen, who I'll show you, and did a training there. In that province, heroin is cheaper than bottled water, beer, or milk, to give an example of how available access really can drive the epidemic. Again, around this time, you can see the risk groups that I think we're all familiar with, but this particular 9.4% was improper blood transfusion and plasma donations, primarily in the central part of China, in Hubei and in Hunan province in particular. Again, here's Hubei province, and you can see the most dense at this time by 2003 was in Hunan, then in a neighboring province and in Xinjiang, and then in the central provinces. And this is Hubei province itself, and as you drill down, you can see that it's not evenly distributed. It depended on how many plasma donor exchanges had been going on in these particular places, but in Shanfan County, Suizhou, Xishui, in Badong County, and what I've also shown over time, University of Chicago and other infectious disease specialists went to mentor the clinicians we were working with to follow up on the results of training, and these are the various places. So we've had University of Chicago clinicians working in Hubei province since 2006. The size really does matter in China. It's overwhelming and difficult to picture from afar, but this province is essentially the same population as France. There are 69 million people, 32 cities, 347 counties, 91,000 villages. And so in our planning with the Hubei CDC, we tried to think about rationally providing training to not to 73,000 doctors, but to a reasonable portion, triaging to the hardest hit counties. And as I've told you, it was among the highest prevalences. At that time, there were over 4,000 known patients and about 20 per week. There was very limited ART. They were beginning to manufacture it, but it was just coming in 2004. And so mostly patients, as here, were treating opportunistic infections in hospitalized patients, but struggling to try to overcome them. They had no virus loads. There were some CD4 cell counts, but access was limited. And actually, the concept of treating anyone who was asymptomatically infected with HIV, like most longitudinal primary or preventive care, is somewhat foreign in China. What you're treated for is an acute illness, not longitudinal preventive care. And we faced many of the other same issues, like stigma and discrimination, that most people were presenting in hospitals. And unfortunately, because these are poor farmers who received $5 or about 40 yuan for their plasma and then got HIV in the process, were too poor to pay for a complete hospitalization. So that was a huge problem.
We were a little confused, but I think you just clarified it.
Yes.
So these were people who were infected in the course of
donating plasma.
Not receiving.
Not receiving. Now that also happened, but this is people selling their plasma, impoverished farmers who had no other reliable source of income, getting about $5 for that. What they did was to pool, like blood types, take plasma and then reinfuse blood cells. A very efficient way of transmitting HIV. Unthinkable that this occurred in the 1990s, but it did.
So they pooled the red blood
The red blood cells and then reinfused red blood cells.
Wow.
I mean, yes. So there was this new antiretroviral therapy, but the DDI that they were manufacturing was the powdered DDI with high toxicity. There was, as I mentioned, very little access to laboratory diagnosis and monitoring tools, though the CDC was rapidly undertaking to take care of this. So we went in two phases. We started with a core of the doctors who were starting to see patients, who wanted to learn, who had both self-selected and were chosen by the Hubei CDC authorities as both the best clinicians but also the most likely to be able to teach and share that information. And then phase two was essentially to repeat that over and over in each local county, and to do that with a resident expert, so someone who stayed and lived in China and worked with those clinicians over time. And I emphasize that because I think over time what we've learned is you can do a lot of seminars and trainings, and that simply will not work if you want to establish effective care. You have to have somebody on site to mentor, to answer questions, to be there longitudinally, and I mean months for months. So my colleague lived in Wuhan for a year and a half to oversee this process. So there's this Caroline Teeter, who's a physician's assistant and an MPH. She lived in Wuhan for a year and a half. Some of you may remember Gao-Chi Chung, who came here for a month in 2006 as a Clinton Fellow, who's since gone back and has been a wonderful faculty member for many of our students and faculty, now as an ID attending at one of our partner hospitals, the Zhongnan Hospital. And probably the best part of this story, again, so mentoring is one I would underscore. The other is when you are preparing to leave and stop your training, what is sustainable? What can you leave that will live beyond you? So Caroline's job after she left was taken over by this physician, Aijing Zhu, who was at a Medicine Sans Frontières clinic in Shanfan, also in Hubei province, who we then hired to come and occupy this role as mentor and coordinator for the HIV training programs. She's still there, so every time we go back to Wuhan, I see her and we do a little more training, which is really terrific. And these are the initial master trainers. That was Dr. Zhou, who I think you remember from that small town with the very first patient that I saw. And we would do didactics lectures in the morning, and then we do case discussions in the afternoon, small group sessions and informal sessions to try to break up, not just have lectures, but to have case management and small group discussions. Many of you met Diana Liu Ping, who came with the delegation from Wuhan last April. It was very important that we had the Wuhan Bureau of Health director supporting this work. This is Gui Zhen, who I personally revere, just one of these remarkable people who just works all the time. He took AIDS orphans into his home at one point. He was actually visited, honored by Premier Wen, visiting his home and visiting his hospital, and he's like a national figure now, quite a legend. And the local CDC director, Jean Fashan, is the one with whom we did most of the planning and who really understood the importance of operationalizing this effort. There's Gui Zhen talking to a mother and a child who had some retarded development. Both of these two have HIV, were on antiretroviral therapy, their T cells were rising, and they were doing very well. They're a success story. Here's a couple with HIV being interviewed by Diana Liu Ping. And this is in Badong, which is near the Three Gorges in western Hubei province. This is a very rural area. It took about 5 hours by bus and then an hour by car to get to this little clinic. And there was about 25 people there waiting to be seen and by the local doctor, and I saw those patients with that doctor, or Dave Petrak or Jean-Luc Benoit did. We did, at that time, have to take English language materials and translate. Now there's abundant materials in Chinese and that are, I think, on a par with international standards. Another fortuitous thing was that the free ART network manual, which is essentially the Chinese national guidelines, were developed in 2004. So right as we were starting our training, we had not our own guidelines to rely on, but the national guidelines that I credit Eric Gooseby and the Pangea Foundation and the Clinton Foundation with helping them to organize. I sat on that panel, and that again made it much easier for us to work in China. And there's a variety of different materials that we put together. And I'll just show you some more pictures. This is a gentleman with HIV doing very well on stavudine, on D4T, but he has thenar atrophy and fairly moderately severe peripheral atrophy, peripheral neuropathy, which we see as both with HIV and with that drug. If you're a visual person, you can get a sense, I think, of how we went about this, of training a core of trainers. Initially, it was 50. It ended up being closer to 100 master trainers over time. They would go to each of their provinces and train another 20 to 50 physicians who are actually working out in the county level and the associated nurses and technicians. And you can see gradually how that went from the provincial level. We did our trainings in the provincial capital in Wuhan, but most patients are too poor to be able to afford travel to Wuhan. So the most important thing in this context was local care, and that was at the county and the township and village level. This is with a local CDC doctor and a patient with HIV and the group of clinicians around, again, answering questions, looking fairly fiercely. She was afraid that she was under, we were doing a monitoring and we were going to either penalize her or take away her salary, and none of that occurred. In fact, they were doing a terrific job in Badong. And we were able to show in the training and the short-term outcomes that people did better on a little test given after the training than they did before. The scores improved by 23%. And we could see the master trainers, as they would present cases themselves, grow in confidence as lecturers and teachers. That was a very important part of this. So there were 2,000, it was actually more than this, HIV clinicians trained, and a total of 10,000 health workers who at least had stigma reduction, engagement in the process for at least a half-day lecture, and the standardized materials, and then requests from other provinces to repeat this model. And as I mentioned, I went to Xinjiang and then also to Yunnan province with the Clinton Foundation and shared what we did with them, because they have a large effort in Yunnan province. And this is gradually how we scaled up our training over time, ending right at the end of 2007. And this is another young woman with HIV. During that time, about 3,000 patients were engaged in care. About 1,000 were enrolled on antiretroviral therapy. We also honored our trainees with certificates and any way that we could try to stimulate both their interest and their continued engagement. We saw a decline in the mortality over time from 49% down to 8.8%. A loss to follow-up rate that's phenomenal, 1.1%. You just don't get lost. The health department knows where everybody is. One of the things in China that's striking is you need a visa to travel from one province to another province. So movement is actually quite restricted. That has its disadvantages, I'm sure, but from a public health perspective, actually some real advantages. We had very good medication adherence. Just like in our country or in Africa, when patients have been or are sick, there's no need to incentivize taking medications if they work. As long as we were able to address the toxicity, we saw CD4 cell counts, not surprisingly, and then this remarkable 82% decline in mortality. I think also by convening this technical advisory group in Hubei province, they've since met and helped the Hubei CDC with other implementation issues, with how to do virus loads, how to standardize them, how to implement the guidelines, essentially. The training of trainers process itself, and then not only did we use this larger guideline document, but we made little handheld documents for guides for the clinicians to use in the field. We were able to publish this outcome in Health Affairs. This was in 2008. And, you know, for me, the greatest thing was to see that this is pretty much mirroring the curve from HIV that we saw here in the city of Chicago from about 1995 to 1998. A little more sharp, dramatic decline. This was in the protease inhibitor era, but still a very comparable outcome. And I think we saw that with the leadership, we had the support of the dean of the Health Science Center in Wuhan. This made all the difference in the world, and that's actually continued into the work that I'm going to describe next. Those personal relationships with the CDC and with Wuhan University, I think have allowed us then to have considerable candor and credibility in the way that we've been able to interact on other issues. And that's invaluable. I think it's very difficult to achieve that starting from scratch. As in elsewhere with HIV, this notion of integrating care, prevention, and testing is really, I think, increasingly recognized as critical. And so training that covers each of those is important. And there were lots of obstacles that they're still working on. I mentioned the barriers of access to hospital care. China is actually engaged in a health insurance reform much the same as we are. They've guaranteed access to primary care to all of their citizens, and they're trying to make that happen with an insurance model. So they're going through a change much the same as we are, a change that will take them away from a tertiary care model and more towards a primary care model. Stigma and discrimination have been critical issues all along. That is still a very serious issue in China and everywhere in the world. And the structural and systemic limits to healthcare and the healthcare institutions, though they have now, every local county CDC has a CD4 machine. Almost all of them can now do virus loads. So they've rapidly brought their care up to the modern standard.
Resistance testing?
Say again?
Resistance testing?
They're doing resistance testing only in Wuhan, so that's next. And I think that they'll get there. And I think one of the lessons that we saw was that in the medical education training, they loved some of the experiential work that we did with that you have to do in HIV to address stigma, to put health workers at ease that they themselves are not at risk or that their risk can be managed, to talk about homophobia, to talk about chemical dependency in ways that are consistent with a healthcare model. And they took to the kind of training that we did, especially small group sessions, case discussions, where we were engaging the clinicians. But we could see that their training had not really had that as a routine. So differential diagnosis, clinical reasoning, even a good patient presentation was not commonly a common part of our experience. They would put up an X-ray and say, this patient's had diarrhea from 4 months. What do you think is wrong? And then it would be on us to ask questions and to try to understand the remainder of the patient's clinical history, which they could provide, but looking through the chart and coming up with all the information. So we saw deficiencies in medical education and learned from Wuhan University of their intention to reform medical education. So that leads to the second half, and then I'd like to entertain further discussion. Clearly, from the UNAIDS World Report, what we need to do now, and this is the direction that Eric Gooseby is taking, our own PEPFAR program, the UNAIDS, the Global Fund with limited resources, rather than having HIV-specific and exclusive interventions, to try to provide longitudinal, durable, sustainable healthcare systemic improvements that not only address HIV, but also all of the other problems that are faced in resource-poor settings. Malaria, for example, tuberculosis, even just infant respiratory and diarrheal illness, the major killers. And there's very good evidence that in resource-poor settings, the HIV infrastructure has actually led to benefits in these areas. And one of them that comes up over and over, so support for institutions, support for human resources. Education reform in medical and nursing schools and technical schools. What's happening in Africa, of course, is task shifting. So nurses are being asked to do what doctors traditionally have done, write prescriptions, for example, even make diagnoses. Physicians' assistants or community health workers are being asked to do increasingly what nurses are doing, simply to address the gaps in human resources. This is less of a problem in China, where, if anything, there are too many doctors with their hands on any one of these patients. At the county level, at the CDC level, the CDC manages the T cells and the antiretroviral therapy, but a primary doctor is responsible for other care. Coordination of the medical system is more the issue in China, but we saw that there was this need for medical education reform. Certainly a medication supply chain, but also professional certification, who should be doing HIV care and addressing that and other infectious diseases. And then, as I've mentioned, issues in securing government and leadership responses, health reform to ensure access to primary care, certainly removal of some of the legal barriers for HIV, and this continuing affirmation of human rights, of the rights to health, the rights to freedom from discrimination, and how to implement that at the level of health policy. So that led us, at the end of this, not so much the end, but in the sort of the next phase of the HIV training, Wuhan University asked me and my colleagues here at the University of Chicago if we would help with medical education reform, if that would be of interest here. And I went to Holly Humphrey and to Scott Stern. We met with them when they first visited here in 2006. And if I have to say what it wasn't me particularly. I do think it's the extraordinary reputation of the Pritzker School. But the thing that caught their attention most was Scott Stern and the CPPT, which those of you who know Pritzker, I think, is the jewel in the crown of the way that teaching is done. It's really an extraordinarily effective, interesting, exciting course that is the first time that basic sciences are wedded to clinical sciences. And it's all available on the internet. It's taught here by a pathologist working with a clinician. So I have to say, the first time I heard about it was in this meeting when Dean Joe was here and Scott Stern came and explained it to them. And I also was sold that this was a terrific course and one that they needed in China, frankly, to help bridge that understanding between basic sciences and the clinical sciences. And from that,
Just say a quick word about that.
Please.
That course has a very rich tradition here at the University of Chicago. Actually, before the University of Chicago Medical School was known as the Pritzker School. A man named John Oakman came here in 1968 from Columbia and worked to develop that course between about 1970 and 73. And you rightly call it a jewel in the crown, because it's been that jewel since John developed it. He ran it for the first 10 years, turned it over to Pierce Gardner.
Pierce Gardner, right.
He ran it for about 10 more years. But each person who's taken it over has modified and built and refined the program to make it his or her own project. And I think you're absolutely right. Scott has brought great energy and innovations to the program.
Well, I'll show their names, but Aliyah Hussein is the pathologist in the pair, and I just think the pathology department here is extraordinary for the breadth and the clinical knowledge. And I'll jump ahead. That's what our colleagues in Wuhan have been most surprised by, is how much clinical medicine, using a vignette to teach, but actual clinical medicine the pathologists know and bring to bear in that course. It has them scratching their heads because they're basic scientists and they haven't had that wealth of experience to share with their students. So this is our little team, Sujata Mehta and Ivy Morgan. I think Ivy's here. And these are those faculty. So what I'm very proud of is those that are in yellow, including medical students, are those that have either been to Wuhan, and many more than once, or those that are going. And so from a gleam in Scott Stern's eye in 2006, this has really become a rich exchange of both students and faculty, and I think extraordinarily productive. And I'm just going to focus on a few of the elements because I don't want to take too much time for this. But what we said initially, what we wanted to do, and this was their request. So we're in the position of consultants providing technical assistance for reform, essentially to meet international standards by faculty and student exchanges, by live case conferences interactively, and by the development of materials and both cultural and literal language translation of training methodologies. And I have, and I think other faculty members have particular interests or they have made special requests. For example, obviously, the public health and infectious disease side, my entire section has been very active in. And we've just sent a fellow to start doing some research in gram-negative drug resistance in the hospital. So that's underway. I'm going to talk a little more about family and community medicine because they've asked us not only to make a medicine clerkship for family and community medicine, but to actually build an entire department, which they lack. And this all ties into the health reform in China, which I think allows this to capture a very important moment in Chinese healthcare. And that's that. And then research in both in medical education reform and in the implementation. I'll show a few pictures again. This was the 11-member delegation. Some of you met some of these folks. I was very proud that the dean of the Health Sciences Center, Dean Zhou Punyifang, came here for a week and gave a week of his time to this effort. So you can see that his signature is all over this program. And here they are talking to my sage colleague, Jean-Luc Benoit, in his office, and at the Pritzker School in class and meeting with UC faculty. So we, in 2006, signed a very broad general letter of agreement to collaborate in some way, which was actually very important to just get the institutions to talk to each other, and then a much more detailed memorandum of understanding that essentially agreed to the structure that I'm going to describe to you. There's Ivy, there's Sujata, and then I'm very proud also that Jingyi Fan, who's an instructor here in anatomy, joined us as a volunteer, and now it turns out she and her husband are returning to Wuhan, and so we're talking about how she can continue to work with us from that side of the equation in Wuhan, which I think will be very helpful. So this is their 5-year curriculum. The first year is something like, remember these are high school graduates, so this is something like a general overview of education. And then these 4 years are fairly comparable to our 4 years of medical school. So a first year of basic science, a second year introducing the clinical sciences, third year of clerkship, fourth year of clerkships and electives, okay? Again, for those of you who are familiar, you've seen this before, this is our new Pritzker reform. And I just want to say that to my mind, our case in Wuhan with some of the reluctant faculty, because believe me, there was pushback in Wuhan to partnering with this institution from Chicago that doesn't speak the language. Our case was strengthened by our own reform process for the Pritzker School. So in other words, we were not going to say, here's how we do it in Chicago and we do it right. We were going there saying, we are in the process of our own review of what works and what doesn't work, informed by faculty and students, and we would be happy to share that process with you. And so mostly sharing the process of how to rethink your own structure of medical reform, medical education, and how you might think of doing improvements. Yes?
It went by pretty quickly, but I didn't see an ethics course in that curriculum.
No. There absolutely was not. And you're right on top of, I think, one of many of the biggest issues. So, and I'm coming to it because I think it's a huge issue. In the medical school, P2S2 is ethics, professionalism, medicine and society, a mixed bag, but it includes, I think it includes a very critical part of the curriculum, and of course it's longitudinal all the way through the medical school. It also includes communication with patients that starts very early in the first year, that has fundamentally a human rights basis, a respect for the individual and for autonomy. And these are concepts that I'll say at least are different, if not actually completely different in China. And again, remember, we are the consultants and they are our client, and they've asked us to help them to get this explicitly in those areas, which is, I think, a great benefit. But it doesn't make it any easier, in fact, in the implementation. And I think this is going to be our biggest challenge, or one of them, is that subject. A couple other things, the scholarship and discovery longitudinal track, they're very attracted to and are interested in. And I would say the other, now they have just implemented the first year, and I'm coming to that, but what they've adopted, which I think is really quite a brilliant reform that led by Carl Matlin and Jean Chang and everyone in the basic sciences, is orienting this towards, first of all, anatomy and then cells and molecules, putting together the curriculum for biology, biochemistry, genetics, and then tissue structure and function, so essentially histology and physiology, and then response to injury, pathology, immunology, pharmacology. And that organization has been adopted and is now being implemented in this reform curriculum. CPPT I've already focused on. They love it and they're trying to do it. And I would say the clerkships are most similar to the way we organize our clerkships, but they don't have a core curriculum which an individual student is expected to learn, which I think is quite an important part of the evolution of the medicine clerkship in the last 10 years here and around the country. So here's what they have come up with as of November 2009. Their first year is still largely the first year with a lot of English language, political science. Thoughts of Chairman Mao is the biggest grade that you can get in the first year. There's also, they're intending an earlier exposure to clinical medicine starting in the first summer. They have organized the basic science, as I mentioned, by those three. A whole year they will devote to CPPT, which Scott Stern and Aliyah Hussein are very happy about. And then the clerkships. And of course, the devil here will be in the details of how they go about this and what the content is. The key things that we've focused on is this synthesis of clinical pathophysiologic information, basic science integration, and reducing teaching time overall, reduction in the emphasis on lecture time, more small group and self-directed learning, more emphasis on infectious disease and on family and community medicine, more of an emphasis on clinical reasoning and medical decision making, trying to foster students as teachers and researchers in development and to promote that idea from the first year. I mentioned the earlier exposure. They also asked for a lot of help on student evaluation. Right now they have single textbooks and large tests at the end of term, no formative evaluation structure particularly. So a great deal of interest in how to nurture and encourage students and then help them to understand how they're doing over time. And then broader use of new technologies. And I think the great thing that Scott Stern is accomplishing that could have application many other places in the world is we will make the CPP web available to the students and faculties in the reform effort. And that's not actually to the entire CNET, but to just the CPPT web, so that they can use this technology and have that for their CPPT. Now, that's all in English, of course, but that will be with real-time translation. And I should say a word about language. We were asked to provide this assistance in English in an English language-based curriculum. Well, that's great, but in fact, the students, about half the students can read very well but not speak very well. The other half have some, and some very good, spoken. For the faculty, it's closer to a quarter who have good spoken English and most who can read and understand English. It can't all be done in English, and so translation has been a huge part of this, backwards and forwards, with the staff that we have in Wuhan as well as our staff here. And that's a big challenge. We do have a study now of this. We're in our IRB looking at the student and faculty knowledge and attitudes, the outcomes of reforms, and then some focus surveys that we're planning this April in the medicine clerkship and in the community health centers. 2 first-year medical students, Kate Lemler and Yuka Leong, completed the baseline surveys with our staff in Wuhan. In 265 first years, about 100 other class members and 90 faculty members. And another 2 senior students will go this April, and they're going to do focus surveys, including OSCEs, oral structured clinical exams, for those students in medicine, looking at this before the implementation of reform, and then we'll be able to track longitudinally how they do. And this is, I think, what's most remarkable is the faculty, our colleagues in Wuhan, were willing to offer to any of the first-year medical students to participate in the reform. They got 165 volunteers, and then they randomly selected the 50 who will go into the reform curriculum. All the other students will just continue in the standard curriculum. This will expand over time, this will contract, and we'll be able to look at the outcomes over time in both, which is really a terrific opportunity. So I'll just mention this community and family medicine and show you a little bit about it, then I want to finish. I mentioned that there's a national health reform and that the Wuhan Bureau of Health has provided access to the local community health centers that they control so that Wuhan faculty can teach medical students in them. And that's new, and I think that means something is beginning that's very, it will be fun to be part of. They've also extended an invitation to our community and family medicine faculty. This is Sarah Ann Schumann and now Mary Egan, who have traveled there. Also for placement of the students there and faculty development, both in the community health centers and at Wuhan. They are intending to hire a full-time family and community medicine course director. And I should say they have created course director positions for all of these other, all the positions, all the courses that I've mentioned. They didn't have a specially designated person nor dedicated time in the past. And that's making a big difference for faculty ability to attend to this. They also have in these community health centers a traditional Chinese medicine site in each one of them, so that will be both a place to learn and to work on the integration of that with Western medicine. And this is their local catchment area. I'm going to show you the Qinshan Community Health Center. Serves a population of about 37,000. Focuses on women, children, pregnant women, and the elderly, though they have quite a bit of hypertension, diabetes. They have 160 staff, including 17 Chinese medicine staff. And they already have some experience in training of their local physicians. And so this is the Qinshan Center. This is actually their own slide set. This is the second floor for Chinese medicine. It just looks like a very standard clinic. In fact, it used to be a hospital. You can see the nice entrance room. This was a model, so we're actually very used to touring people. This was created 4 years ago and already has become something of a model for the movement towards community health centers. This is in Wuhan. This is the traditional Chinese medicine center where we saw acupuncture, moxibustion, and herbal medications. I was very impressed, so I'll just show you the geriatric facility. So they had an overnight hospital for non-severe types of conditions where you might be able to just get by with a day or two of observation, and I think capacity for about 15 beds. In-home care, and when we were there with Sarah Ann Schumann, we went on 3 home care visits just to see how they do them. A lot of health education, a lot of physical exercise, so I think, and regular medical examinations, the rational drug use, a special elderly project for patients over age 65 who live alone, who are in home. Diagnoses, home care, mobility. So I was impressed by the physical therapy that they have, and I think I have, yeah, there's a little gym and wheel bars, a whole rehab center right there in the community health center. So Sarah and Schumann thought, boy, we need some of the things that they have for use in the Chicago Family Center. Regular home visits and on-site drug delivery. So this was our group outside of the community health center. That's Sarah N. Schumann. It was remarkable that she brought her 9-year-old daughter, Noah, who did a blog on the visit and for her local elementary school here in Chicago. And there we are going to a local community, going to a home care visit, seeing 3 different elderly folks who were essentially had to be confined to home. Part of the problem here is they have no ADA. When you're disabled and you're on a 5th floor walk-up, it's very difficult to get around, but it's wonderful that they're able to provide this kind of home care. And then I mentioned the use of these new technologies, including time-space, which hopefully will provide access in future for medical education, not just for CPPT, but literally for all of the Pritzker curriculum. And I salute Scott for that. So I've talked about the HIV training and how that led to an impact in infectious disease and HIV. And then the next steps from that being including training and mentoring of physicians in medical schools, not to mention linking prevention and care and expansion of laboratory sites. And that medical education reform is really a key part of that. This is a national effort in China. Many different universities are going about it in different ways, but I think it's important that this is a role that the University of Chicago can play in Wuhan with all of these different elements, and this is just a repeat, really, of everything that I've just said. So, you know, the kinds of ethical issues and things that we confronted in both of these 2 programs were related to HIV, stigma and discrimination, and the government participation, a lot of anger from the communities that we worked in directed towards the government and those that participated in that. So a need for some compensation from the government. And as everywhere in the world, even though there was access provided, it was piecemeal, and it only happened in the more affluent counties initially and then the poorer counties at a later time. I think this was a very big one, this lack of privacy and confidentiality, and this, again, this issue of communication, that when we saw patients, it was usually in an open room with several people standing around. Sometimes there would be community members just walk in, and not a sense of privacy at all or an expectation of privacy. In fact, if I would try to take a patient into an individual room to examine them, they would be very upset by that. The expectation was just that you would share that with everybody there, the medical people in the first tier, but then anybody else who happened to come in. So it's a very different environment, and I think one where we need to learn how we can translate that into meaningful education. Pam?
I interfaced with the Chinese physicians who were mentoring here as part of the HIV international training, and they were not responsive to secondary prevention messages.
Right.
I mean, I would ask the faculty, well, do you see IV drug users? Do you see homosexuals? And no, they don't exist in my country, was the answer. And it was in their mind, it just didn't exist, which makes secondary prevention rather problematic if nobody's engaging in sexual relations outside of marriage or using IV drugs on the opium trade route. Has that changed over time?
Well, it has changed. There's much more openness. SARS actually led to a large part of this. I'm not sure this would have been possible if it hadn't been for the SARS epidemic, where the national government was so embarrassed that in relation to HIV, they were going to do it right. They were going to, well, I won't say be transparent, but be more transparent than with SARS. And, you know, I would say, to take an example, they decided that methadone maintenance and needle exchange are effective public health interventions, which I agree with, which the international HIV community completely agrees with. And in the 2 or 3 years since they made that decision, they've provided access to more than 50% of people with drug use to either a methadone maintenance or a needle exchange center. Phenomenal public health response. When they decide they're going to do something and that it works, they don't talk about it, they just do it. So that's a terrific example of where suddenly they changed their minds, and now they're way ahead of the United States, frankly, in that activity. I'm really at the end, so I'd be happy to keep talking. And questions or comments, please.
Taking things maybe even more globally again, do you think that either project would be possible, or elements of this project possible, in countries that weren't growing and having a GDP growing at 5%, even in the face of a
Oh yeah, I absolutely do. I don't think
anything like this in Angola or someplace like that.
I do. The HIV training work that we did, the total budget for that over 5 years was about $500,000. It was very frugal, actually. Training, I think, at its core is a fairly inexpensive intervention. So in answer to that part, I do think that. Now, the mentoring is, to my mind, is the challenge. You actually have to have people willing to be there, and that takes someone committed to that activity.
But does even the expenditure, while it's frugal, not presume an infrastructure of some kind that
Yeah.
can accommodate that, a basic
Yes.
set of educational standards?
No. You're making a great point. For example, in Malawi, they have terrible time just getting people to stay. No, I think that's a separate and a much more difficult problem. That's where taking the available people who are there, task shifting, empowering and doing short-term training of community health workers for targeted issues is one response. But no, that's where I think the problems are much more difficult. Problems faced by sub-Saharan Africa are just huge, and it is a human resource problem. So I don't think that's quite comparable. Although I would say medical education reform is needed in those regions. And another way to frame this, I'd turn it around. In this era, like at the Cape Town AIDS meeting just this last year, there was superb presentations of both research and achievement of scale-up from national governments, from ministries of health in South Africa, in Mozambique, in Rwanda. The expertise now resides in resource-poor settings for this effort. And that's a sea change from even 5 years ago. And it really has, I think, it challenges us in this country and PEPFAR to be careful about spending a lot of money for jet fuel and jetting off to conferences. And the expertise is now in those areas. The drugs are in those areas, the diagnostic technologies, and the clinical research expertise is there. So now it's a responsibility of those countries to take maximal advantage of that and essentially do what we did in this country. That's make the same level of care available in rural settings, train the physicians, try to come up with low-cost alternatives to that. And I would add to that human resource development so you can have a quality of life and be a clinician in rural Malawi. Because 10 years ago, that was just not achievable. I believe it's becoming achievable now. You were next.
I was wondering about the topic of prevention and cultural differences. I didn't hear a breakdown, for example, a gender breakdown with regard to the disease. We know that so many women in Africa, in contrasted to the United States, are HIV positive or have AIDS, and that has to do with cultural views as well. I wonder how that figures in your picture of China.
Well,
And I guess one other comment that, there's a certain irony in your list there. The notion of privacy that is so sacrosanct in our own culture around AIDS and HIV, and some of the cases that we deal with at times have to do with the quandary of a known partner to whom her partner's HIV status may not be reported. And whether that kind of difference in our cultures, how that carries over or connects.
There's a high prevalence in women. They're not at parity with men, but they're getting there. There's been a lot of sexual transmission even in central China from the plasma donation or from injection drug use. So when at the time we were working, it was about 20%. It's well above that now. It's coming closer to parity in China. So it is a big issue, and women's rights and the need for women to have self-empowerment with HIV prevention and the need for an effective microbicide, that's as urgent now as it was 10 years ago. There are a few bright lights, the possibility of there should be some trials in the next year or two on that using tenofovir or other antiretrovirals that are hopeful. That
Testing pregnant women for AZT.
Yeah, that actually is being done extremely effectively and efficiently. When they discovered the problem that they had and they began testing, they tested actually aggressively and large populations. And you could argue about the method and whether there was, the process, but compulsory testing of pregnant women was done, and antiretroviral therapy is provided now aggressively through PMTCT, and they've really dramatically reduced their rate in children and in drug users, I should say, because of what I mentioned before, of entrance into care or the criminal justice system and the use of methadone maintenance and needle exchange. So the terrible problem in drug users that they might have had, it appears they've got a handle on. So that's only a partial answer, and I really accept the other issue. This thing of privacy and yeah, I mean, we did in Beijing. We did a training of health workers to help in outreach for the health workers to those three populations: commercial sex workers, which are mostly women, gay men, and drug users. And this was in the Dongzheng district, where Tiananmen Square, right in the heart of Beijing. It was the most remarkable thing I've ever taken part in, because we arranged to take all the health workers to a gay bar in Beijing. It was a half a mile away. They said they'd never met a gay Chinese person. It was like the world, it opened. That was my role, to introduce them to a community a half a mile away. So there are things that I can do as a crazy American who's too public about everything and just bowls in, that they themselves can't do, or that they've asked us to help them with. That was a remarkable moment. The same thing with commercial sex workers, but there was a much more pragmatic matter. The mamas who oversee the barber shops or the karaoke bars, all these different places where there's commercial sex, were very much on top of this. And they had their girls tested on a regular basis, and so at that moment, that change had already taken place. Dan, you had a question.
Yeah, well, you mentioned a little bit. You talked about the IV drug abuse. The IV drug users are being cared for now, but in terms of sort of the gay population there, I mean, it sounds like it's still pretty much they don't believe it exists.
Yes. Well, they used to say we don't have any gay people in China. That doesn't happen anymore. So let's all understand. So what are the terrible still stories worldwide about HIV? 50% of new cases are in young people, aged 13 to 21. 50% of new cases are in homosexually active individuals. Still. And that's absolutely true still in China as well, or rather it's an unattended population. So the whole Gates initiative actually in China has been to address this problem that hasn't been addressed by anybody else in urban centers, lively, large gay communities in Beijing and Shanghai, basically doing outreach, HIV prevention, education, testing. They're doing that same, reinventing the wheel over and over again.